Good day, everyone, and welcome to today's lecture, Special Tests in Hematology. So, this is your second to the last lecture topic for this course. Now, our learning outcomes are discuss the purpose and importance of each test, explain the principle of the different special tests in hematology, enumerate the reagents and equipment used, know the specimen to be used for the procedure, and learn the reporting and interpretation of the test results. So let us first discuss leukocyte alkaline phosphatase stain or your lab stain. So alkaline phosphatase activity is present in neutrophil and band and sometimes in B lymphocytes. The amount of lab present will vary in different diseases. So the lab stain is useful in differentiating a leukemoid reaction which will have an increased lab activity from chronic myelogenous leukemia, which has a decreased lab activity. So, if the lab score is increased, this can be found in the following conditions. So, in pregnancy, infections accompanied by neutrophilia, polycythemia vera, people receiving corticosteroids, aplastic anemia, multiple myeloma, myelosclerosis, obstructive jaundice. Now, the lab score will be decreased in CML, PNH or paroxysmal nocturnal hemoglobinuria, sickle cell anemia, hereditary hypophosphatemia, marked eosinophilia, and in sideroblastic anemia. Now, there will be normal lab scores in the following conditions: untreated hemolytic anemia, lymphosarcoma, viral hepatitis, and secondary polycythemia. Now, what is the principle? Blood smears are fixed in citrated buffered acetone. When placed in the incubation solution containing naphthol ASMX phosphate and fast blue RR, the alkaline phosphatase present in the white blood cells liberates naphthol ASMX, which then couples with fast blue RR to form an insoluble blue compound at the site of alkaline phosphatase activity in proportion to the amount of enzyme present. The smears are then counterstained. The degree of reactivity is determined by scoring each of 100 neutrophils according to the amount of precipitated dye present. So the specimen used is fresh capillary blood or heparinized whole blood may also be used. Reagents and equipment are listed. So the air dried smears are fixed using citrate buffered acetone for 30 seconds, and this is then rinsed with running distilled water for 45 seconds. So do not allow the smears to dry. Afterwards, place smears in the staining solution for 30 minutes at room temperature. Afterwards, wash the smear again in distilled water for 2 minutes. And once again, do not allow smears to dry. Afterwards, counterstain with Mayer's hematoxylin for 10 minutes. Rinse again using distilled water for 3 minutes. Afterwards, when you are done staining, examine smears microscopically in the thin portion of the smear using the oil immersion objective. Count 100 consecutive neutrophils and band forms and grade each one from 0 to 4 plus on the basis of appearance, so the quantity and intensity of the precipitated dye in the cell. The cytoplasm of the cells will be colorless to pale blue. The total rating for the 100 neutrophils is determined by multiplying the number of cells in each group by its rating and adding these numbers together for the total lab score. The normal range for this test is 30 to 185, but should be determined by each laboratory. So if you see this picture here, so each neutrophil is graded according to the intensity of the color of the cell. So the grading: 0 if no staining, 1 plus faint and diffuse staining, 2 plus if pale with a moderate amount of blue staining, 3 plus if strong blue precipitated staining, and 4 plus is the gray if there is deep blue or brilliant staining with no visible cytoplasm. So again, let's view the picture. So the score there is beside the cell. Next, let's go to Heinz body preparation. Now, what are Heinz bodies? These were discussed during your RBC morphology. So these are inclusions within the red blood cell. So Heinz bodies are precipitated hemoglobin. So these occur when the red cell glycolytic enzymes are not able to prevent oxidation of the hemoglobin molecule. These appear as single or multiple, round, oval, or serrated bodies about 1 to 3 micrometers in diameter in the red blood cell. So these appear close to the cell membrane and found in the presence of unstable hemoglobin, as seen in the following conditions. So G6PD deficiency. Heinz bodies can also be found following ingestion of oxidative drugs where the quantity consumed is sufficient to neutralize the red blood cell reducing mechanisms. So, examples of drugs commonly associated with the presence of Heinz bodies are sulfonamides, nitrofurans, antimalarials, dilantine, streptomycin, and favamines. Now, the spleen will remove the Heinz bodies from the red blood cells and therefore will not be commonly seen in fresh blood unless the patient has undergone splenectomy. Heinz bodies, as I have discussed during my RBC morphology laboratory briefing, cannot be seen on right stained smears. These can only be detected using supravital stains such as new methylene blue, brilliant crescel blue, crystal violet, and methyl violet. Now, the principle for this test: whole blood is mixed with crystal violet stain. Slides are prepared and examined for the presence of Heinz bodies. Now, the specimen to be used is fresh whole blood anticoagulated with either heparin or EDTA. Now, the reagents and equipment used are listed on the screen. So the stain here is a supravital stain, so we'll be using 1% crystal violet. Or you can also use new methylene blue or brilliant crescel blue. So you have to examine the smear using oil immersion objective and the presence of Heinz bodies. So as you can see in this picture pointed by the black arrows, those are the Heinz bodies. Again, these can only be visualized or seen when stained with a supravital stain. So the presence of Heinz bodies in a freshly drawn sample may indicate an oxidizing drug or chemical has been ingested in a quantity to overwhelm the normal red cell reducing system, causing denaturation of the hemoglobin. Or A drug such as primaquine has been ingested by an individual with a red cell glycolytic enzyme deficiency so that the hemoglobin is not protected from oxidative denaturation. Another why or a reason why there are Heinz bodies in the patient sample, the patient has thalassemia or an unstable hemoglobin. Now, another procedure is preparation with acetyl phenylhydrazine. So, the principle here, whole blood is mixed and incubated with acetyl phenylhydrazine. So, a normal control blood is prepared in the same manner as the patient's specimen. So, Heinz bodies will be formed when the red cells are exposed to the reducing substance, which is acetyl phenylhydrazine. The blood specimens are then stained with crystal violet, and patients whose red cells have defective reducing systems will show greater than 32% of red cells containing 5 or more Heinz bodies. So the reagents are flashed on the screen. So the following conditions are critical to the accurate performance of the procedure. The phosphate buffer should have a pH of 7.6. At an increased pH, there will be faster development of Heinz bodies, while a decreased pH slows down Heinz body formation. Acetylphenylhydrazine concentration, so the amount and speed of Heinz body development will increase with increased concentrations of acetylphenylhydrazine. A decrease in the ratio of reagent to red blood cells will decrease formation. Therefore, in the presence of anemia, the concentration of red cells should be adjusted to near normal values. So, how do you achieve that? You remove the plasma from the specimen in order to obtain valid results. Now, another, the amount of oxygenation, which is determined by the bubbles introduced by the pipette during mixing, influences the final results. So, the more oxygenation, the greater the development of Heinz bodies. So, capillary blood should not be used in this procedure. Now, the acetylphenylhydrazine solution should be used as soon as possible after preparation due to its unstable nature. In this method, Heinz body formation is increased in G6PD deficiency, 6-phosphogluconate dehydrogenase deficiency, glutathione reductase, glutathione synthetase, and glutathione peroxidase deficiency, and in triose phosphate isomerase deficiency. Now, the next test that we will be discussing is red cell zinc protoporphyrin. So, measurement of zinc protoporphyrin in red blood cells as diagnostic test for iron deficiency anemia and a screening procedure for lead poisoning. So, during the development of heme, iron is inserted into the protoporphyrin 9. In iron deficiency anemia, where the utilization of iron is defective, zinc is incorporated into the protoporphyrin 9 ring, which then attaches to the heme site on globin, forming a non functional molecule that remains for the life of the red blood cell. So, the principle for this test, protofluor reagent is added to anticoagulated whole blood in order to completely oxygenate the hemoglobin. A drop of this mixture is placed on a cover slip and inserted into the hematofluorometer. Light with a wavelength of 450 nanometers is focused onto the blood mixture. At the same time, a portion of this light beam is deflected onto a photocell for measurement to allow for correction of any variation in the light intensity. The light that comes in contact with the blood specimen causes the zinc protoporphyrin present in the red blood cells to emit light of a wavelength of 595 nanometers. This light is collected onto a photomultiplier tube, which produces a current in proportion to the amount of light reaching it. The current produced is directly proportional to the micromoles of ZPP or zinc protoporphyrin per mole heat. The result is unaffected by the hematocrit. So the specimen for this test is whole blood anticoagulated either by heparin, EDTA, or sodium citrate. So blood up to 1 week old may be used unless it is hemolyzed. Capillary blood may also be collected by filling 2 to 3 heparinized microhematocrit tubes. So for the procedure, first, always allow reagent, calibrators, and controls to warm to room temperature. And turn on the hematofluorometer 30 minutes prior to testing. You also have to check the instrument to verify that it is set in the correct mode for the desired units of reporting. So the top setting is for results in microgram per DL. So this will be used if patient hematocrit is 42% or above. Bottom setting is microgram per DL. So this is used if the patient hematocrit is lower than 42%. And the middle setting is for micromole ZPP per mole heat. After checking, you have to blank the instrument. So using a cover slip, so you have to check that the cover slip to be used must be free from any dirt, scratches, or fingerprints. So after blanking, you calibrate the instrument. Now you're ready to run the patient sample. So mix the patient sample well and place 0.05 ml of whole blood into the test tube. Add zero point 0.1 ml of protofluor reagent to the tube and mix well. Once the reagent has been added to the patient sample, testing must be completed within 5 minutes. So place 1 drop of the test mixture in the center of the cover slip in the sample holder. Spread the drop evenly over the sample area and make sure there are no bubbles. Immediately place the sample holder in the instrument and take a reading by pressing the measure button. If the reading flashes 999, the result is greater than 600 micromole ZPP per mole heme or greater than 270 micrograms per DL whole blood and should be reported as such. Record the result, remove the sample holder, and discard the cover slip. Now, what are the interferences and considerations during testing? So, the presence of hemolysis and increased bilirubin will cause falsely elevated results. Excessive quantities of riboflavin, about greater than 10 times the normal serum concentration, will also cause falsely elevated results. Another, only one reading of each sample drop. So after 5 seconds in the instrument, photo decomposition may begin to occur and test results will be unreliable. All reagents, controls, and patient specimens should be at room temperature prior to testing because fluorescence is affected by temperature. So low temperature yields low results. The test sample on the cover slip must not contain any bubbles. The presence of bubbles in the drop will cause falsely low results. Now let's go to the detection or identification of hemoglobinopathies. Let's start with sickle cell test. So hemoglobin solubility test, or sodium dithionite tube test, or sodium hydrosulfide tube test. So either of these are the names, the different names of the test, but these are just the same. So this is the most common screening test for hemoglobin S, or your sickling hemoglobin. So decreased solubility of deoxygenated hemoglobin S in solution, producing turbidity. So the principle of hemoglobin solubility test: when red blood cells are added to the working solution contains sodium dithionite. The red cells immediately lyse due to the saponin. So saponin here is the detergent-based lysing agent present. Hemoglobin S in the reduced state forms liquid crystals and yields a turbid appearance. So blood is added to a buffered salt solution containing a reducing agent. So the reducing agent here is the sodium dithionite, or your sodium hydrosulfide, and a detergent-based lysing agent, which is your saponin. Now, the saponin dissolves membrane lipids, causing the release of hemoglobin from the red blood cells, and the dithionite reduces the iron from the ferrous to the ferric oxidation state. Ferric iron is unable to bind oxygen, converting the hemoglobin to the deoxygenated form. Deoxygenated hemoglobin S polymerizes in the solution, which renders it turbid, while solutions containing non sickling hemoglobin remain clear. So, the specimen to be used for this test is whole blood anticoagulated by EDTA or heparin or sodium citrate. The specimen may be up to 3 weeks old. So, for the interpretation of results, it is reported as negative if the lines on the reader scale are visible through the test solution. So, if it's negative, meaning there is no sickling hemoglobin present. If it is positive, it is interpreted as positive if there is a turbid solution. So there is failure to see the lines on the line reader scale through the solution due to turbidity. So in this test, or in this picture, the one on the left is negative. So you can see clearly the lines of the reader scale through the solution, while the tube on the right is positive. So it is turbid. It's a turbid solution, meaning there is sickling, or it's positive for sickling hemoglobin, or there's presence of sickling hemoglobin in the patient sample. So if positive, perform hemoglobin electrophoresis to verify the presence of hemoglobin S. Now, the sources of error for this test are: so these conditions cause false positive results. So, hyperlipidemia, because this will have a turbid sample. So, the sample is turbid already. So, this can cause a false positive result. Another is when too much blood is added to the test solution, When the patient has a high WBC count, again, this one will cause turbidity in the patient's sample and also hemoglobin bars. Now, these situations will cause a false negative result, or these conditions will cause false negative results. So if the patient has a low hematocrit and infants with less than 6 months of age. Now, another test for sickle cell, we have the sodium metabisulfite method. So, sickle cell anemia or sickle cell trait are caused by hemoglobin S. So, the principle for this test or method, whole blood is mixed with sodium metabisulfite, which is a strong reducing agent which deoxygenates the hemoglobin. Under these conditions, hemoglobin S present in the red blood cell causes the formation of sickle-shaped red cells. So the specimen to be used is whole blood, anticoagulated either by EDTA or heparin. Capillary blood may also be used. So place 1 drop of blood on a glass slide and add 1 to 2 drops of 2% sodium metabisulfite to the drop of blood. Afterwards, mix well using an applicator stick. Now place a cover slip on top of the sample and press down slightly to remove any air bubbles and to form a thin layer of the mixture. Wipe off the excess sample. Using a syringe and a 19 gauge needle, carefully rim the cover glass with petroleum jelly, completely sealing the mixture under the cover slip. So this prevents evaporation or drying up of the sample. So examine the preparation for the presence of sickle cells after 1 hour using the high power objective. The red cells may appear as holly leaf form. So this shape is often found in the sickle cell trait and when present is reported as positive. So if there is no sickling present at the end of 1 hour, allow the preparation to stand at room temperature for 24 hours and re-examine at that time. So for the interpretation, positive if sickle cells or the holly leaf form of the cell is found. It is reported as negative if you find normal looking or slightly crenated red blood cells. So as you can see in this picture, it is positive since there are sickle cells present in the smear. So sickle cells or the holly leaf form must come to a point or points to be considered positive. So elongated cells with a rounded end must not be confused with sickle cells. So sickling of red blood cells is maximal at 37 degrees Celsius and decreases as the temperature lowers. So this method cannot distinguish between sickle cell trait from sickle cell anemia. If the sickle cell preparation is positive, perform hemoglobin electrophoresis to determine the presence of the trait or anemia and to identify the type of sickling hemoglobin present. So sodium metabisulfite or sodium bisulfite may be used interchangeably in this procedure. So always run a positive control when performing this test and do not perform tests on infants with less than 6 months old age. So now let's go to quantitation of hemoglobin F. So approximately 65 to 90% of the total hemoglobin at birth is hemoglobin F. By the age of 4 months, there is approximately 10% hemoglobin F present, and by 6 to 12 months of the level of hemoglobin F is less than 2%. So increased amounts of fetal hemoglobin are present in hereditary persistence of fetal hemoglobin, sickle cell anemia, acquired aplastic anemia, and other hemoglobinopathies. Hemoglobin F may also be elevated in megaloblastic anemia, paroxysmal nocturnal hemoglobinuria, leukemia, myelofibrosis, and refractory anemias, as well as during pregnancy. So the classic alkali denaturation test is accurate and precise to quantify hemoglobin F in the 0.2% to 50% range. Most human hemoglobins are denatured on exposure to a strong alkali, but hemoglobin F is not. So the hemoglobin F can be separated and its concentration compared with that of other hemoglobins. So, consistent methodology is required to ensure accurate results. So, there are two methods for alkali denaturation. We have Betke method and Singer. So, let's discuss first the principle of Betke method of alkali denaturation. So, a red blood cell hemolysate is prepared to lyse the red blood cells and free the hemoglobin. This test utilizes the characteristic of fetal hemoglobin to resist denaturation in an alkaline solution. The hemolysate is added to cyan methemoglobin reagent and then exposed to an alkaline reagent, sodium hydroxide, for a specified period. So during this time, normal hemoglobin is denatured or destroyed, but the fetal hemoglobin remains intact. So ammonium sulfate is added to halt the denaturation process and to precipitate the denatured hemoglobin. The solution is filtered, measured spectrophotometrically, and compared with the spectrophotometric readings of the original cyan methemoglobin solution. So you have to determine the percent of hemoglobin F present. So the specimen for this method is whole blood anticoagulated with EDTA. So you should prepare the hemolysate on the same day the specimen is obtained. So the hemolysate may then be frozen at negative 20 degrees Celsius for up to 7 days or longer. So the reagents and equipment to be used, we have cyan methemoglobin reagent, saturated ammonium sulfate. Again, this reagent will precipitate the denatured hemoglobin. Our alkaline reagent is sodium hydroxide. We also have 0.85% sodium chloride, carbon tetrachloride, Wattman filter paper, tubes, graduated centrifuge tubes, normal and abnormal hemolysis control, test tubes, water bath, and spectrophotometer. So for the procedure, pipette zero point 0.5 ml of the patient's hemolysate and the normal and abnormal control hemolysates into respective tubes containing 9.5 ml of cyan methemoglobin reagent. So label tubes as total hemoglobin. So this gives a hemoglobin concentration of approximately zero point 0.5 grams per dl. After mix and transfer, 2.8 ml of each of the preceding cyan methemoglobin solutions into each of two labeled tubes. So each test is performed in duplicate. So label tubes hemoglobin F and place the test tubes in a 20 degrees Celsius water bath for 5 to 10 minutes to reach the proper temperature. Afterwards, add zero point 0.2 ml of 1.2 normal sodium hydroxide to the first test tube and rapidly mix. Allow to incubate for exactly 2 minutes. At exactly 2 minutes, add 2 ml of saturated ammonium sulfate to the tube directly into the solution and quickly mix the tube to stop the reaction. Allow the tube to stand at room temperature for 5 to 10 minutes. So filter each of the preceding solutions through Wattman number 42 filter paper. If the filtrate is not absolutely clear, refilter the solution using the same filter paper. So prepare the total hemoglobin specimen for the patients and control. Add zero point 0.4 ml of each of the total hemoglobin solutions to 6.75 ml of distilled water. Prepare this dilution in duplicate. So transfer the filtrates and total hemoglobin solutions to cuvettes and read in a spectrophotometer at a wavelength of 540 nanometers using cyan met hemoglobin reagent to set the instrument at zero optical density. Record the absorbance of all specimens. So the optical density readings should fall within a range of zero point zero 0.05 to 0.50 for maximum sensitivity. If the filtrate is too concentrated, dilute it using distilled water. Now, for the calculations of results, follow the formula that's flashed on the screen. So the optical density of the total hemoglobin is multiplied by 10 because this solution is 10 times more dilute than the hemoglobin F solution. Now let's go to Singer method of alkali denaturation. So the principle is the red blood cell hemolysate is incubated with potassium hydroxide which destroys normal and non-fetal hemoglobin. Addition of the precipitating solution stops this reaction and precipitates the denatured hemoglobin. The non-altered hemoglobin is then measured spectrophotometrically. So the specimen is whole blood anticoagulated with EDTA or EDTA. And these are the reagents and equipment that will be used for this procedure. So prepare again red blood cell hemolysate as described in the Betke method and pipette 1.6 ml of 0.083 potassium hydroxide into the labeled tubes. So two tubes for patient and two tubes for control. So label these as hemoglobin F tubes. So place tubes in a water bath at 20 degrees Celsius for 10 minutes to allow solutions to reach the proper temperature. Label two additional tubes for each patient and control with a name and total label. So this represents the total hemoglobin. Next, pipette 5 ml of distilled water into each of the total tubes or the tubes labeled total. Add 0.02 ml of the appropriate hemolysate to each test tube labeled total. Label another set of tubes into which the hemoglobin F tubes will be filtered. When the potassium hydroxide has reached 20 degrees Celsius, add zero point 0.1 ml of the first hemolysate to the appropriately labeled tube, at the same time starting a stopwatch. Rinse the pipette in the solution 6 to 8 times and then mix the tube well. After exactly 1 minute, add 3.4 ml of precipitating solution and thoroughly mix by capping the tube and inverting at least 6 times. Immediately filter the mixture into the appropriately labeled hemoglobin F tube. Next, transfer the filtrates and total hemoglobin solutions to cuvettes and read in a spectrophotometer at a wavelength of 540 nanometers using distilled water to set the instrument at zero optical density and record all readings. Filter each of the preceding solutions through Wattman filter paper. If the filtrate is not absolutely clear, refilter the solution. So, prepare the total hemoglobin specimen for the patients and control by adding zero point 0.4 ml of each of the total hemoglobin solutions to 6.75 ml of distilled water. Transfer the filtrates and total hemoglobin solutions to cuvettes and read in a spectro at a wavelength of 540 nanometers. Using cyan methemoglobin reagent to set the instrument at zero optical density. Record the absorbance of all specimens. The optical density readings should fall within a range of 0.05 to 0.50 for maximum sensitivity. If the filtrate is too concentrated, dilute it using distilled water. So for the calculation of results, just follow the formula that's flashed on the screen. So please take note 0.203 is the conversion factor for the hemolysate dilutions. So the following aspects of the test are critical and must be carried out as indicated in the procedure. So concentration of sodium or potassium hydroxide, incubation time and temperature. The hemoglobin concentration of the hemolysate should be within 9 and 11 grams per dl. The filtrate must be crystal clear, and concentration of the ammonium sulfate. Now let's go to acid elution test or the Play-Hauer-Betke test. So this is employed to assess the distribution of hemoglobin F in the red blood cell to determine whether hemoglobin F is present in the same amount in all red blood cells or whether it is present in varying amounts in only some of the red blood cells. It is also helpful in diagnosing hereditary persistence of fetal hemoglobin, and the Clay-Hauer-Betke slide test is used to determine the presence of fetal red cells in the maternal circulation during pregnancy. So it's used to estimate the volume of fetal maternal hemorrhage to determine if an increased dose of Rh immune globulin or ROGAM is needed for an Rh negative mother who delivers an Rh positive baby. So the specimen, so obtain 4 blood smears from the fingertip or the toe or heel, or make blood smears from venous blood collected in EDTA anticoagulant. Obtain a similar blood specimen for a normal and abnormal control at the same time the patient's blood is collected. For best results, blood should be less than 6 hours old, and the smear should be fixed within 2 hours of preparation. So for the principle of acid elution test, blood smears are fixed with ethyl alcohol and then incubated in a citric acid buffer solution. In an acid medium, so the pH is 3.2 to 3.3, hemoglobin F is resistant to elution from the red blood cell, while other types are removed from the red cells. The slides are stained with hematoxylin and erythrocin B. So hematoxylin stains the white cell nuclei and erythrocin B stains the red cells. The smears are then reviewed microscopically to determine the presence of hemoglobin F, and the percentage of red blood cells containing fetal hemoglobin may be assessed. So the reagents and equipment. So adult hemoglobins are eluted from the RBCs or red blood cells, whereas hemoglobin F resists acid elution and remains in the cell. When the cells are subsequently stained, red blood cells containing hemoglobin F will take up the stain, whereas RBCs containing only adult hemoglobin will appear as ghost cells. So as pointed by the red arrows, so these are the cells that contain hemoglobin F. So once you're done staining, examine the slides microscopically using oil immersion objective for the presence of hemoglobin F. So red cells containing large amounts of hemoglobin F will stain a deep pink. So again, as I've mentioned, those that are pointed by the red arrow, those are the fetal cells. So the intensity of the pink staining is directly proportional to the concentration of hemoglobin F. Cells containing normal amounts or less than 2% of hemoglobin F will stain as very pale ghost cells. So to determine the percentage of red blood cells containing fetal hemoglobin, count the number of red cells in 3 to 5 microscopic fields and determine the average number of red cells per field. Examine 20 to 25 microscopic fields, counting the number of red cells containing hemoglobin F, and then calculate the percentage of RBCs containing hemoglobin F using this formula. So sources of error and comments. So reticulocytes may resist elution and would be confused or mistaken for cells containing hemoglobin F. So in hereditary persistence of fetal hemoglobin, the amount of hemoglobin F in each cell is constant. Therefore, all of the red blood cells are consistently stained. So in diseases like sickle cell anemia, thalassemia, acquired aplastic anemia, and several others hemoglobinopathies, there is inconsistent staining of the red cells because the amount of hemoglobin F present in the red blood cells varies. So the pH of the citric acid phosphate buffer is critical. So a pH below 3.1 may cause elution of hemoglobin F from the red cells, while a pH above 3.3 may retard the elution of non-hemoglobin F from the cells. So a temperature above 25 degrees Celsius during fixation in ethyl alcohol will inhibit elution of normal hemoglobin. So ethyl alcohol concentrations above 80% may cause the elution of hemoglobin F, while concentrations below 80% may cause morphologic alterations. So positive control smears may be prepared in advance. So add cord blood to EDTA, so 1 drop of 2% EDTA and 1 ml or 1 ml of whole blood. So hemoglobin H preparation, so alpha thalassemia. In alpha thalassemia, there is an excess beta chains due to a deficiency in the production of alpha chains. So the excess beta chains form beta tetramers. So hemoglobin H is composed of beta tetramers. So, in the presence of an oxidant such as brilliant crescel blue, hemoglobin H will precipitate within the red blood cell and form many small inclusions. So, for the principle, red blood cells containing hemoglobin H are removed more quickly from the circulation by the spleen or by the reticuloendothelial system. Therefore, red cells containing hemoglobin H are relatively young cells and when centrifuged will lie near the top of the red cell layer. In this procedure, the blood is centrifuged in several microhematocrit tubes. The top layers of red blood cells are removed and incubated with brilliant crescel blue stain. During incubation, hemoglobin H present in the red cell will denature and precipitate within the cell. The hemoglobin H bodies and any other denatured hemoglobin will be stained by the brilliant crescel blue. Smears are made, air dried, and examined for the presence of hemoglobin H bodies. So the specimen, whole blood, using EDTA or acid citrate dextrose as the anticoagulant. Excess amounts of anticoagulant may interfere with the staining process, so it should be properly collected. Fresh blood samples should be used, so it should be less than 8 hours old. Reagents and equipment. So you have to examine approximately 50,000 red cells or 200 oil immersion fields containing 200 to 300 red blood cells per field. Hemoglobin H bodies are multiple, evenly distributed bodies in the red cell that may be described as resembling the pattern of a golf ball. The H bodies stain a bluish green in color, in contrast to the blue purple of our reticulocyte. So the results are reported as positive or negative for hemoglobin H bodies. So another picture, again, you can clearly see the golf ball like appearance of the hemoglobin H inclusions in the red blood cell. So in hemoglobin H disease, 10 to 100% of the red cells may contain these inclusion bodies. However, in alpha thalassemia trait, only a few red blood cells, 0.01 to 1% of the red cells, will be seen with H hemoglobin H bodies. In order to detect other unstable hemoglobins by this technique, the blood stain mixture should be incubated for longer periods of time, from 4 hours to 24 hours, since these unstable hemoglobins require longer incubation for denaturation and precipitation. So Heinz bodies may stain with this procedure and may be differentiated from the H hemoglobin H bodies by the fact that they are larger, fewer in number, and most often appear along the membrane of the red cell. So diagnosis of an unstable hemoglobin should be confirmed by other tests such as the heat precipitation test and hemoglobin electrophoresis. Now let's proceed to autohemolysis test. So the result will be increased in hereditary spherocytosis. So in the past, the procedure is used to differentiate several types of congenital non-spherocytic hemolytic anemias using glucose and ATP. So the principle is one portion of sterile defibrinated blood is incubated for 48 hours at 37 degrees Celsius. A second sample of the defibrinated blood is incubated with a specific amount of glucose. The percentage of hemolysis in each specimen is then determined spectrophotometrically. Normally, and in certain disorders, such as hereditary spherocytosis, the amount of autohemolysis is reduced in the presence of glucose. In other pathologic states, the addition of glucose does not effectively decrease the autohemolysis. The degree of hemolysis that takes place in this procedure, with or without glucose, is a function of the metabolism and membrane functions of the red blood cell. So the specimen to be used is whole blood, whole defibrinated blood. So about 15 to 20 ml from the patient and a normal control. So please take note, this procedure should be performed in a sterile environment, or you should maintain the sterility of the equipment and the reagents that will be used. So we will be using sterile glass beads, 3 to 4 millimeters in diameter, water bath, cyan methemoglobin reagent, 10% glucose solution. Again, it should be sterile. Sterile, 0.85% sodium chloride, sterile screw cup test tubes, sterile Erlenmeyer flask, sterile pipettes. So again, as I've mentioned, the entire test procedure must be under or run under sterile conditions. So how do you defibrinate the patient's blood? So add 15 to 20 ml of whole blood to a 125 ml sterile Erlenmeyer flask containing 15 sterile glass beads. Gently rotate the flask until the hum or noise of the beads on the glass can no longer be heard. So that's about 10 minutes of gentle rotation. So label 8 sterile screw cap tubes from numbers 1 to 8. And then place 2 ml of the patient's defibrinated blood into test tubes 1, 2, 3, and 4. Place the remainder of the patient's defibrinated blood in an empty sterile screw cap tube and centrifuge at 1,500 times gravity for 10 minutes. Remove the serum and place in a sterile screw cap tube in the refrigerator. Repeat the previously mentioned step, adding 2 ml of controlled blood to tubes 5, 6, 7, and 8. Add zero point 0.1 ml of 0.85% sodium chloride to tubes 1, 2, 5, and 6, and gently mix the tubes. For tubes 3, 4, 7, and 8, add zero point 0.1 ml of 10% glucose solution. And again, mix the tubes. Incubate the 8 test tubes at 37 degrees Celsius for 24 hours. At the end of 24 hours, gently mix the test tubes by carefully inverting them 5 to 10 times and incubate once again for an additional 24 hours. At the end of 48 hours, inspect each test tube for contamination. So how will you know if it's contaminated? A greenish discoloration or there is a bad odor. If there is no contamination, pull test tubes 1 and 2, 3 and 4, 5 and 6, and 7 and 8 together. Again, 1 and 2 together, 3 and 4 together, 5 and 6 together, 7 and 8 together. Perform a duplicate hematocrit on each of the 4 specimens, average the duplicate readings, and record the result. So what we will be testing or looking for is the hemolysis. So you have to record the optical density readings of the following solutions diluted with cyan methemoglobin reagent using a spectrophotometer set at a wavelength of 550 nanometers, using the cyan methemoglobin reagent as the solution blank. So patients incubated whole blood, patients incubated serum without glucose, patient's serum with glucose, patient's non-incubated serum, and the four control tubes. So for the interpretation of results, normal, it's reported as normal if less than 4% of hemolysis in the blood specimen with no added glucose, and less than 0.5% hemolysis in the specimen with added glucose. In hereditary spherocytosis and triphosphate isomerase deficiency, autohemolysis in the absence of added glucose is greatly increased. Autohemolysis in added glucose is reduced. So if you recall this picture, so again, without glucose, for normal, the hemolysis is less than 4% with no added glucose and less than 0.5% hemolysis with added glucose. So in hereditary spherocytosis, as you can see in this picture, for without glucose, the hemolysis is greatly increased. And the hemolysis with glucose has been reduced in hereditary spherocytosis. So in pyruvate kinase deficiency, increased hemolysis in both specimens. So source of error and considerations, there may be considerable methemoglobin formation in the procedure. So cyan methemoglobin method must be used for measuring the amount of hemoglobin in the serum. Hemolysis may be increased by bacterial contamination. Next, let's go to ascorbate cyanide screening test. So this is a non-specific screening procedure for detecting deficiencies in the pentose phosphate pathway. So positive results for conditions conditions that will yield positive results for ascorbate cyanide screening test are G6PD deficiency, but it can also detect deficiencies in glutathione, glutathione peroxidase, and glutathione reductase. So the Jacob and Janty method, the principle here, sodium cyanide and sodium ascorbate are added to aerated whole blood. Hydrogen peroxide is generated by a reaction between sodium ascorbate and oxyhemoglobin. The inhibiting effect of catalase, which is present in the red blood cell on hydrogen peroxide, is blocked by the added sodium cyanide. Unless the hydrogen peroxide is reduced by glutathione peroxidase, it will convert the oxyhemoglobin to a brown pigment. So in a normal blood, the added glucose will be utilized by the pentose phosphate pathway to reduce the hydrogen peroxide. If there is an enzyme deficiency present in this pathway, hydrogen peroxide will not be reduced and the blood will become brown in color. So the specimen is 3 ml of whole blood anticoagulated either by heparin or ADTA. So normal control mixture should be red color. So interpretation, if it's red color, that is normal, and it's positive if the solution is brown in color. So if it's brown, there is enzyme deficiency in the pentose phosphate pathway. The brown color will be most evident after 2 hours of incubation. Next is glucose 6 phosphate dehydrogenase fluorescence screening test. So when red cells are exposed to an oxidant drug, the activity of the pentose phosphate pathway increases. If one of the enzymes in the pathway is decreased or absent, for example, G6PD, reduced glutathione cannot be produced and oxidation of the hemoglobin takes place. So when red cells containing G6PD are mixed with the test reagent containing glucose 6 phosphate and NADP, the following reaction occurs. So the resultant NADPH fluoresces under long wave ultraviolet light, while NADP does not fluoresce. So the specimen, whole blood, anticoagulated with either EDTA, heparin, or acid citrate dextrose. So for the interpretation of results, positive if there is presence of fluorescence and negative for lack of fluorescence. So for normal G6PD activity, the maximum fluorescence is at 10 minutes. So blood specimens may be collected on filter paper for use in this procedure. False normal results may occur in the presence of elevated platelet or white blood cell counts. Reticulocytes normally contain a high concentration of G6PD-H. Therefore, if a patient has had a recent hemolytic episode, the test results may be falsely normal. Hemoglobin has a quenching effect on fluorescence, and no fluorescence or decreased fluorescence will be present as long as the drop is moist. So once dry, the fluorescent spots on the filter paper are stable for several hours but will begin to fade within 24 hours. Now, another test is pyruvate kinase test. So, pyruvate kinase is an enzyme in the Embden-Meyerhof pathway. A deficiency of this enzyme causes congenital non-spherocytic hemolytic anemia, and is probably the most common type of anemia. So, crenated and irregularly contracted red blood cells may be found in this deficiency. Now, the next test is glutathione reductase test. So glutathione reductase is a red blood cell enzyme in the pentose phosphate pathway. So it catalyzes the reaction of the transfer of electrons from NADPH to glutathione in forming reductase glutathione. A deficiency in this enzyme causes drug-induced hemolytic anemia. Next is we will be discussing the tests for PNH, or paroxysmal nocturnal hemoglobinuria. So, sugar water screening test is the simple screening procedure for PNH. So, what is PNH? This is an acquired disorder in which the patient's RBC are abnormally sensitive to destruction by normal constituents in plasma. So, this is characterized by red cell hemolysis during sleep, hence the name nocturnal hemoglobinuria. If positive, the sucrose hemolysis procedure should be performed before a diagnosis of PNH is made. So the specimen is citrated whole blood. So for the interpretation of results, negative or within normal if the hemolysis is less than or equal to 5%, borderline if the hemolysis is 6 to 10%, and positive if greater than 10% hemolysis. So sources of error and comments: prior to testing, centrifuge a small portion of the patient's blood to check if there is no initial hemolysis in the plasma. The use of defibrinated blood may cause false positive results due to hemolysis of the traumatized red blood cells. The test should be performed within 2 hours of obtaining the specimen. Next is sucrose hemolysis test. This is used as a confirmatory test for PNH when the sugar water screening test is positive. So the principle: washed red blood cells are incubated in an isotonic sucrose solution containing normal ABO compatible serum. At low ionic concentrations, red blood cells absorb complement components from serum. Because PNH red blood cells are much more sensitive than normal red blood cells, they will hemolyze under these conditions. The normal red blood cells will not. At the end of the incubation period, the mixture is examined for hemolysis. So the specimen, once again, is citrated whole blood. So washed red blood cells are incubated in an isotonic sucrose solution that contains normal ABO compatible serum. So under low ionic conditions, red blood cells take up complement components from the serum. Since PNH red blood cells are again more sensitive than normal red blood cells, they undergo hemolysis in this environment, whereas normal red blood cells will remain intact. After the incubation period, the mixture is then examined for evidence of hemolysis. So, for the interpretation of results, negative or within normal if hemolysis is less than or equal to 5%, borderline if hemolysis is 6 to 10%, and positive if greater than 10% hemolysis. So, increased hemolysis may be found in some patients with leukemia or myelosclerosis, whereas patients with PNH show 10 to 80% hemolysis. Results of the sucrose hemolysis test should correlate with the acid serum test. So, the acid serum test or the HAM test, the principle here is the patient's red blood cells are mixed with normal serum, with the patient's own serum, and with the patient's normal serum inactivated to destroy the complement. A weak acid is added to the inactivated serum tube, to one of the normal serum tubes, and to the patient's serum tube in order to adjust the pH of the mixture for maximum hemolytic activity. Normal red blood cells are incubated in acidified serum as a normal, so this will serve as a normal control. So after incubation, all tubes are inspected for hemolysis. Normally, there will be no lysis of the red blood cells in any of the tubes in the test. However, in PNH, the patient's red cells will hemolyze in the presence of non-activated acidified normal serum and in the patient's own inactivated acidified serum. So again, in this picture, there will be no lysis of the red blood cells in any of the tubes in the test for normal red blood cells. If a patient has PNH, again, the red cells are unusually sensitive. So the red cells will hemolyze in the presence of non-activated, acidified, normal serum and in the patient's own inactivated, acidified serum. So serum viscosity test. So viscosity is the property of a fluid that resists the force causing it to flow. So the viscosity of serum is primarily a function of the concentration of protein and is determined by comparing it with the viscosity of distilled water. So the principle of this test, the serum viscosity is determined by comparing the rate of flow of serum to the rate of flow of distilled water through a viscometer. The patient's serum is placed in a viscometer and the time required for the serum to flow from one mark to a second mark is measured. This time is then compared with the time required for distilled water to flow the same distance in the viscometer. So there will be increased serum viscosity in the following conditions: IgM monoclonal gammopathy, some lymphomas, IgA and IgG myelomas. The specimen here is 5 ml of serum. So this is an Oswald viscometer. So kindly make sure to familiarize yourselves with this equipment. So for the part labeled A, that is the top measuring line. The part labeled B is the low measuring line. Labeled C is the reservoir bulb, and above that is the reservoir arm. So the measuring arm is near the low or in between the top measuring line and the lower measuring line. So for the procedure, how are you going to do the serum viscosity test? So place 5 ml of serum in the reservoir bulb through the reservoir arm. Allow several minutes for the serum to reach 37 degrees Celsius. So during this time, remove any air bubbles in the serum by gently blowing through the aspirator attached to the top of the measuring arm. Using suction, draw the serum up into the measuring arm above the highest line. Release the suction. As the serum flows down through the measuring arm, start the stopwatch as soon as the top of the serum is even with the top measuring line. Time the passage of serum between the two measuring lines. As soon as the upper border of the serum is even with the lower measuring line, stop the watch. Record the flow of time of the serum. Repeat the steps 2 more times and average the 3 readings. So remove the serum and rinse the viscometer several times using 0.85% sodium chloride, then 2 rinses with distilled water. So do the procedure again using distilled water. Now for the results, you calculate using the formula relative serum viscosity equals flow time of serum divided by flow time of distilled water. So the flow time of distilled water through the Oswald viscometer is 59 seconds. If not in use, the viscometer should be sealed with a parafilm, and the procedure may be performed at room temperature if water bath is not available. So symptoms of hyperviscosity syndrome are generally present in the patient when the relative viscosity is between 6 and 7, but may also be present with a test result as low as 4. Okay, so again, the conditions that have an increased serum viscosity are Waldenstrom's macroglobulinemia or IgM monoclonal gammopathy, lymphomas, and IgA and IgG myelomas. So the references that I used for this lecture, Hematology Principles and Procedure by Barbara Brown and Rodax. So if you have any questions, feel free to ask me in Cello. So you can email me through Cello. And that's it for the lecture. Thank you so much for listening.